Somebody's coming back. Sorry, I'll just have a little play with this. That does it. Okay, let's get rid of that one. That's it. That should work. Can you see that?
Yes, Prof.
Thank you. Right. Okay, I know how much you all love renal scans, so I thought I'd talk about those. So we're going to talk a little bit about renal physiology and nuclear medicine, different radiopharmaceuticals, dynamic renography, static imaging, a little bit about things like reflux studies, captopril, and renal transplants. Now, just saying, the reflux studies are going to talk about indirect ones because the direct ones we'll do in pediatrics later in the week. So renal nuclear medicine, what I mean by the only consistent test of renal function, it's the only test we can do where we can compare different tests and the differences are meaningful. We can do other tests such as ultrasound, we can do even dynamic CT if you want to irradiate the patient a lot. But the results are qualitative, not quantitative. Although I suppose renal size on ultrasound is a bit of an exception. But if you want to know about renal function, then you need to use nuclear medicine, really. Now, there are lots of other ways to look at renal anatomy, and obviously things like ultrasound are quite good at looking at cysts and the dilated renal pelvis. CT, you can look a bit at perfusion, size and shape of kidneys. MR, you can look at other features, particularly blood flow is quite good with MR. Urine flow tends to be quite low and doesn't really get picked up by MR. So this is just some of the fancy stuff you can do with other things. So this is a patient who has got a stenosis in their renal artery, and this is done with a CT angiogram. And you can get these really quite fancy pictures, but they are anatomical. What it doesn't tell you is, does that stenosis affect renal function? And there's no way, even with these pretty pictures, you can actually calculate that. So even having done these fancy pants pictures, then the renal team still need to ask for a renogram to know whether or not that stenosis is affecting function. Likewise, this is a transplant looked at under MR, and the patient's had a gadolinium injection, and they can look at the arterial and venous phasing of that with MR. But again, it's not really telling you whether or not that transplant is working. If that transplant has a problem where it's not working, even ATN, the MR is pretty insensitive at finding that. So nuclear medicine is functional imaging. So what we need to do is have something which has a contrast to surrounding tissue, and that contrast is a functional contrast. It's not like CT, which is to do with density, or MR to do with protons, or ultrasound, which is reflectivity. So that's where we are placed to work. So what is a tracer? Well, I know that we use them all the time, but this is a substance which has a physiological pathway and doesn't disturb that pathway. So for example, you can use intravenous contrast such as iohexol, but the iohexol is so dense, it actually changes the way the kidney works. It's not really very good for looking at renal function. And also, you should be able to quantify a tracer. For that, we use a very small amount of a chemical in the picograms or less range, whilst with iohexol, it's in the milligrams to grams range. And DTPA is a classic example which we can use for glomerular filtration. But you can't say the same, for example, intracoronary tracers that in CT or in angiography, because they're these actual injections are quite thick, have a high viscosity, and they can actually change flow. So this is a urologist, just to see what they look like. This was taken a few years back when we were still allowed to wear ties and white coats. And this is a urologist who's sitting by some dialysis bags. Each one of these is 5 liters. And that's how much your glomerular filtration rate is in the 24-hour period. So if you didn't reabsorb the urine that you filtered, there are 2 things that would happen. You would need to pee continuously, or need to have a bladder the size of a room, or and you'd need to drink continuously. So clearly we have a way of conserving our urine, our water through our urine. So what comes through the glomerulus is very weak concentration, but it's then concentrated within the nephron, and I'll show you that a bit in it. So we don't really have any pure imaging of the kidney. So what we do is we measure the kidney with various different techniques. So we used to use chromomedia to look at GFR in some countries, but that's no longer available. So we can use DTPA. Now, to get an absolute amount, you can do blood sampling, but to really be good at it, you need to sample from the aorta and the IVC, which is not really practical. You can get a measurement of single kidney GFR by measuring their GFR, total GFR, and then the divided function from a DMSA. And that's done, for example, before a renal transplant to work out which donor kidney to take. So this is the structure of the nephron. So you have the glomerulus, which is a filter system at the beginning, and the blood goes through there. The urine is filtered out in very high concentrations. If you remember, for most normal adults, about 100 mils per minute. That's a lot of urine. But then it's reabsorbed through both the proximal convoluted tubules, and then the loop of Henle, and then the distal convoluted tubules, and then down into collecting duct. And by the time it gets to collecting duct, the urine flow rate has dropped from 120 mils per minute to around about 5 to 10 mils per minute. So this is, and diuretics work in different parts of this. So the thiazides work here, and the furosemide or Lasix or frusemide works on the loop of Henle, and sometimes they're called loop diuretics for that reason. So what kind of agents can we use? For glomerular filtration, we can use DTPA or even the MDP will work. If you want to look at filtration and tubular function, MAG3 is mixed. It's about 20% glomerular and 80% tubular. DMSA itself will look at tubular function. If you want to measure tubular function, then you need to use things like iodine, Hipuran. But there's very little clinical use for that, so we tend not to do it. So if we go back to that diagram I showed you, what happens with most of these agents, both MAG3, DTPA, DMSA, and chromomedia can be filtered. MAG3 can also be excreted by an active process into the proximal convoluted tubule, but DMSA is reabsorbed in the loop. So it maps out your working nephrons, whilst the other agents are then excreted down into the bladder. So this is just to show you can do a renogram with MDP. This is a patient who has got a bit of problems with their renal function, and they've done an MDP, and you can see here rising levels of tracer into both kidneys. This patient has already been given furosemide. So this was showing that the patient has bilateral renal obstruction. And this is a patient who had a bladder carcinoma that was obstructing both ureters. So this was done as a sort of urgent scan, and we were able to use MDP. I wouldn't really use it to do much in terms of quantification, but it can tell you if a kidney is obstructed or not quite easily. And you just use exactly the same protocol as you would when you're acquiring a renogram. So calculating the divided function is done either with an integral or slope method, which looks at the sort of gradient of uptake in the first 2 minutes, or you can use deconvolution and a Rutland-Patlat plot, and they tend to be roughly similar. The though the Rutland-Patlap plot method is much more dependent on the injection technique. And both of them you need to correct for background activity. So radiation dose in nuclear medicine doesn't depend on time, so you can keep imaging for as much as you want. You can do things like transit studies, ureteric peristalsis studies. Again, these aren't particularly useful. They've not remain popular. Or you can measure changes. You can add furosemide or captopril and look at that pre and post those drugs if you want. We can assess renal function, estimate divided function, look at parenchymal clearance and retention. We can assess drainage. We can measure response to diuretic. And so you can look at ureteric peristalsis. That's not done routinely. So here we have a normal renal MAG3, and you can see very nicely uptake in both kidneys, goes to the parenchyma, rapidly collecting system onwards into the bladder. And the curve we see good uptake and rapid clearance. And the divided function is 46-54. You're allowed anywhere between 45 to 55 divided functions. This is a completely normal study. So if we look at the renogram in more detail in the sort of cartoon here, you can see that you might see a perfusion spike early on. And for that, you need to do very rapid frame rate in about 0.5 to 1 seconds, about 30 to 60 seconds. Then for most of the time, we use a 10-second frame rate for about 20 minutes, and you'll see an uptake phase, a plateau phase, or sometimes called peak, and an excretory phase. So you get these 3 phases, and that's what we see on the renogram, or normal renogram. This is a patient who's got some renal impairment, and the first thing you notice is the background does not clear. The background is maintained, and you can only see the kidneys very, very faintly. When you look at the curves, they're very zigzaggy. They look like a sawtooth. And this is because there's high background, and so you don't get a good target to background ratio. And the other thing you'll notice is that they're both of these, sorry, I've lost my cursor, increase over time. That one less so than this one. And that's because both of these kidneys, again, are not really working. Now, when these kidneys are working that poorly, it's difficult to tell whether or not it's due to obstruction or another renal disease. And the divided functions, again, probably don't need so much because you're not going to get a good uptake curve with this kind of interference. So probably the best thing you can see is both kidneys aren't working very well. The left kidney is working slightly better than the right kidney. So we can stress the system, and people have tried different ways of stressing it. Captopril to look at the renovascular system. People have used aspirin, but to be honest, it's a bit rubbish. And people have even suggested using exercise. But again, it's quite difficult to exercise a patient and scan them without them moving. So most people now, if they're going to do that, use captopril. Other people have tried things like Voltarol, but again, this has fallen out of favor. A diuresis enables you to try and assess if the kidney can cope with high urine flow rates. And to do that, you need to adequately hydrate the patient, give furosemide or frusemide, as it's sometimes called, 15 minutes beforehand. It's F-15, and measure the diuresis. And you can see whether or not the diuresis has an effect. You can, of course, do, in children, quite often we give the frusemide with the MAG3 because we don't want to do 2 injections. And if your centre doesn't like giving the furosemide first, you can wait to 15 minutes after the renogram starts and give the furosemide then. But we like to give the furosemide fairly early because its peak effect is around about 15 to 30 minutes after injection. But again, it will depend a bit on what your place does. So this is a F+15. So here we've got a patient who's got accumulation of tracer in both kidneys. On the left-hand side, you can see that there's a little bit of activity holding up here in the collecting system. On the right side, there's initial hold up, and then there's drainage. So this is the right kidney, hold up a bit, then drainage. The left kidney, it doesn't drain. So what happens is at 15 minutes, the technologist has given some frusemide or furosemide, but you can see it makes no difference at all. There's no drainage. So that left kidney is in fact obstructed, and the right kidney is a bit dilated, but not obstructed. So it's perfectly okay to do that as a technique. There's no problem doing an F plus 15. This is an F minus 15 on a very similar kind of patient. It's not exactly the same patient, but they have almost exactly the same kind of renogram. This time it's been given beforehand, so we don't give it again. And what you can see here is there's a bit of renal impairment, but this kidney shows uptake, which increases over time. The right kidney it shows good uptake, and that decreases over time. And that's reflected here in a very nice renogram curve. And here on the left side, there's an increasing curve, and that's an obstructed kidney. So the use of furosemide really helps you to separate between a dilated and a collecting system, an obstructed collecting system. What about static renal imaging? Images really localizes function or loss of function. It's the best way to assess divided function because it doesn't depend on the injection technique or the uptake, immediate uptake curve that you do with a renogram. You can get a better, more accurate divided function. And if you have two-headed gamma camera, you can do a geometric mean that's more accurate than the posterior image. If you want to look at the shape, you can use SPECT. Though there's been no evidence that SPECT quantification really helps. But again, defects can be non-specific, could be due to scarring, it could be due to something else. And obviously in adults, it may have a different role. So in children, we may commonly use DMSA to look for scarring. We can use it to look for acute infection because you can get changes in acute infection, which is why we have to wait 4 to 6 months after the last UTI to look for scarring. Whilst most groups agree that we should use it in children 5 and under, for those who are sort of 6 and over, it's a little unclear how useful it is. You can combine it with GFR to predict the GFR after nephrectomy in patients, for example, in donors in adults. So here we have a 5-year-old with a history of repeat UTIs, and you can see here very clearly that there's one kidney that looks very normal. That's the, if you look on the posteriors, that's the right kidney. And the left kidney looks very abnormal. I think most of us would be very happy to say that there's scar in the left kidney, but the right kidney looks like it's unscarred. You can confirm that by doing quantification, which shows that little bit of remnant on the left. That's the left, that's the right. Sorry, the word left has disappeared, but the left is on this side, is 12% and 88% on the right, which confirms that this is probably a very scarred kidney. Now, because that function is less than 20%, this patient would benefit from a nephrectomy because that scarred kidney is going to result in the patient getting hypertension as a young adult. So that would guide them to doing a nephrectomy. Here we have another patient. This is done with a slightly different gamma camera system, but you can see here a normal sized left kidney and a slightly smaller right kidney with focal defects through it. And this again is in this is an 8-year-old child this time. So this is a patient with multiple scars in the right kidney. So who do we scan? There is some controversy over this, and you may have guidance nationally. Our guidance is that we should scan any child under 6, that's up to 5, who've had 1 episode of UTI. Originally, it was just males, and it became males and females. Then the problem is obviously we need to justify the radiation dose. For girls now, we need to have 1 infection, more than 1 infection, or an organism other than E. coli, because baby girls do get E. coli urine infections quite commonly. So you can have 2 E. coli infections or 1 infection from a different organism. Boys, because of their anatomy, if you remember, is somewhat different, any UTI is counted as requirement for DMSA. Over the age of 6, however, it's really going to be up to the clinician's decision. However, whilst we are hoping that we will reduce hypertension in the future, there's no real definitive proof on that. Other uses of DMSA, we can look at horseshoe kidneys. It's a very nice way to look at horseshoe kidneys, and you can calculate the contribution of each moiety. So that really depends on where you're going to draw your line. I suppose most people would draw the line down the middle, but it's up to where you draw the line between left and right moiety. I'm going to talk a little bit about cystography. Now, contrast cystography, again, is not functional, but can give you some idea of reflux, and is used in particularly in boys, because again, boys, you can use a bit of lead shielding and you can avoid radiating their tender bits. Girls, it doesn't make a lot of difference. It's difficult to lead shield because you don't know where the ovaries are. So we do try to do direct cystography in young girls. And I'll describe that when we do our pediatrics. To do an indirect one, we need to have, in children, we need to have good bladder control and the ability to urinate on demand. And it's quite good for following up after patients have had anti-reflux procedures as well. It doesn't really show anatomy, and you need to have a patient who can cooperate. So children older than 3 who may have issues with cognitive impairment, and possibly some adults, it may be more of an issue. So here we have a reflux study, and what we've done is that the patients had a renogram, the activities in the bladder. We now get the patient to sit up, and if we can, and we sit them with their head, with their back against the gamma camera, and we ask them to void into a commode, which we set up by the gamma camera. It's very difficult to pee when you're lying down, and it's even more difficult to put a commode. So we tend to do it sitting, which is a little bit artificial, because we believe that most reflux that causes pathology occurs at night when the patient's lying flat. And you can see here, this is the bladder curve. So the bladder empties out. And on this side, you can see that there's some hold up on this kidney, which then, in fact, you can see that it starts off empty. See the kidney there, empty, fills, 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 and then later on empties out. So you can see kidney fills, kidney empties. So as the bladder pressure increases as they're voiding, this left kidney fills and then empties. So that's a grade 3-4 reflux. You can't tell between 3 and 4 because you don't have anatomy. The other kidney, the right kidney, which is the blue line, it stays flat. So that's not refluxing. So that's a very gross reflux, and sometimes a lot more subtle than that, but you can see good reflux. Sometimes you can see a reflux in a duplex system during a renogram. So we can see here, we're getting, this is a patient who's got a bilateral reflux, and we're getting what we call yo-yo reflux between the upper and lower parts. And this can often be seen as these sort of saw shape changes in the renogram curve. Sometimes you can see it in the images, often it's not seen, but if you see this saw shape and the patient's not moved, and check that the patient hasn't moved, and the patient has a duplex kidney, they may be refluxing between the upper and lower moiety, and that can give you this sort of yo-yo, this sort of sawtooth appearance known as yo-yo reflux. And they tend to reflux from lower to upper moiety. So the final interaction we can do is captural renography, and this is looking for renal vascular disease. And there's 2 peaks. In the younger patient, it's due to something called fibromuscular dysplasia, which is where there's additional muscle tone around the origin of the renal artery. In older patients, a much more common, if you have a more elderly population, is atherosclerosis. And basically what you should do is 2 studies. You do a baseline study first, and if this is abnormal, then probably don't go on to do a post-captural study, particularly in the elderly, because you could actually damage the kidney. If the baseline is normal, you then give captopril, 25 milligrams normally, and then what you'll see is that there'll be a change in the renogram between the pre-captopril and the post-captopril. And this is all related to changes in the angiogenin converting enzyme drive. So what happens in renal artery stenosis is that the kidney doesn't get enough blood. So to drive getting more blood, it increases blood pressure. by changing the amount of aldosterone produced, and this comes through the ACE, activating the ACE system. And if that is blocked by an ACE inhibitor, then they can't drive more blood into the kidney, so the renogram shows a drop in function of that kidney. And there are three things to look for. One is a delayed peak. The other one is divided function is reduced on the affected side. And the third one, particularly with MAG3, is delayed parenchymal transit. So this is a positive study. So what we've got here is we have a peak that's delayed. You can see that's because there's parenchymal retention of activity on this side. Now, this is not an obstructed kidney. This is a kidney that doesn't have obstruction, but the uptake is delayed in the parenchyma, not in the collecting system. And the divided function has dropped down to 34% in that right kidney. So you see these three changes on a patient that's taken ACE inhibitors. You have to consider there being a right-sided renal artery stenosis. So we select patients who are hypertensive, particularly difficult to treat. They've got asymmetrical renal size on ultrasound, or they've had any kind of unexpected renal failure, diabetes, difficulty in controlling hypertension, or a condition called flash pulmonary edema. This work comes from a multi-center trial done in Europe with nearly 454 patients, of which about half had renal artery stenosis. And this was able to demonstrate that you can find that using captopril, you were able to get a positive study. And this was confirmed by either angioplasty or surgical bypass, and showed that if you do the diagnosis and treat the patients, then their blood pressure does improve. So the sensitivity with post-captopril, this is done with DTPA because an older study was 95%. It's just as good with MAG3. And change in the transit time, i.e. parenchymal transit time, or drop in function gave you the best specificity. And treatment gave 95% of these patients got improvement in blood pressure. So basically, protocol would do a baseline renogram and then repeat study 60 to 90 minutes after 25 milligrams of oral captopril. You stop, if you can, any ACE inhibitors for 3 to 5 days and diuretics for 5 days. That might be a problem if they need them because they've got heart failure. You avoid sodium depletion, and that's mainly done by stopping diuretics. And you give them clear fluids for about 4 hours. And the reason they can't have milk or anything like that, a cup of tea with coffee with milk in, is milk stops the absorption of the ACE inhibitor. So now criteria for analysis is a 5% or greater change in divided function, more than 1 grade change in renogram curve, I'll show you that next, or a 1 grade change in the cortex, basically if the cortex parenchyma increases. So these are the types of changes you can see. So if we assume that 0 is the pre-captopril study, these are the degrees of change you get in the renogram curve over time. So a delayed peak 1 and 2, 3 is a very delayed peak, and by 4 and 5, you're seeing a significant reduction in renal function. All of these in the post-captopril study would suggest they have renal artery stenosis. If you're getting patterns 4 and 5, then they probably got very severe stenosis. So this one is a patient who does have a renal artery stenosis, but it's not so easy. The left kidney looks fairly normal, with good uptake and fairly good drainage, though there's a bit of hold up. And this is in the pre-captopril study. This is the post-captopril study. So if anything, it still looks about the same. The right kidney is a bit abnormal, but it does have uptake and clearance. But here on the post-captopril study, you'll see that if you look here in these later images, there's no retention in the lower pole. And here there is retention in the lower pole, but not the upper pole. And this is because this patient has 2 renal arteries on the right, one with stenosis and one without. So the last area we're going to look at is renal transplantation. So we talked a little about donor assessment, and that's primarily done by doing a DMSA and a GFR, but they may also want to do a MAG3 just to check that kidneys are draining and there's no particular problem. We can do, and that will be in the donors. So then all the other stuff we do is in the recipients. So in the recipients, we might look at any acute postoperative complications or early or late post-transplant complications. So when we're looking at a renal transplant, this is based on something called the perfusion index, which was developed by my ex-boss, Andrew Hilson, in 1976. And that really looked at the first few seconds of uptake in the kidney transplant versus the iliac artery. Now, the reason that can be done is, unlike the native kidneys, which come off the aorta, and of which there are two, in a transplant, there's a single kidney which comes off the iliac artery. So the tracer can either go into the transplant or down the iliac artery. The more that goes down the artery and the less that goes down into the transplant, the sicker the transplant. The use of this has reduced because now with CT and ultrasound guided biopsy, it's much easier to biopsy the kidney, and also new drugs have made early rejection very rare. But we do sometimes see this. This is just some looking at the perfusion index. The problem is the normal range you can see here crosses over with ATN and rejection. So what's important is the change. If the perfusion index goes up, then the kidney has got problems with either ATN or rejection. And as the ATN can only really occur in the first few days, if it's beyond that, then it's going to be rejection. So here we have it actually in reality. So this is the region of interest in the transplant. This is the iliac artery. This is the background. And you can see here the artery curve goes up and down. And here you can see the kidney. And the ratio is 2:1, which gives us a perfusion index of 207. This is some other appearances we may see. This is acute tubular necrosis. Now, the problem with acute tubular necrosis is it's not tubular, it's glomerular, and it's not necrosis, it's ischemia. But it is acute, so the A is correct. But nobody's renamed it as acute glomerular ischemia, so it's still known as ATN, even though it's not tubular necrotic. And what you see in MAG3 is you get, it looks a little bit like renal stenosis, you get uptake in the parenchyma, but no urine produced. And these patients nearly always recover. Now, this often occurs when you have a non-relative donor. So when you have a live donor, the kidney is taken out, put on ice, and put into the recipient very quickly. But if you have a non-relative donor, then normally the donor has to have died at some point and may not even be in the same hospital. So what they do is if the donation goes ahead, the kidney's taken out and put on ice to cool it. And they keep it around about 3 to 4 degrees centigrade. But it may take 24 hours before it gets put into the patient. And that's called the cold ischemic time. And these kidneys nearly always have ATN. But if you're just patient, they normally all recover in about 6 weeks. When things don't recover is when it looks like this. I know it's white, but we call this a black hole, because what you get is a uptake around the transplanted kidney of inflammatory blood pool, but there's no uptake in the kidney, and that is due to irreversible death, and that can be acute rejection, or it can be a clot in the surgically implanted artery or vein, and that transplant is dead and has to come out. You can sometimes see lymphoceles. So this is here we've got over time. There's a transplant. This is a rather old study. You can see the transplant here, and this area, photopenic area, is not the bladder. This is a lymphocele that's developed next to the transplant, and that needs to be drained. Very rare these days. You can get leaks, again rare because surgical techniques have improved so much. This is a leak in the 1970s. This is a leak in the 1980s, and this is a leak in the 2000s. The big clue with a leak is obviously the urine's not in the bladder, and it goes along the fascial plane on the inside of the pelvis. which has this sort of curve to it. And that's a good clue that they're leaking. And again, that needs to be fixed. These days, they tend to fix it by putting a little stent in through cystoscope. And the stent then enables the urine to drain. And what then happens is the ureter just heals around the stent, and they take the stent out. Now, we don't do as many renograms in transplants as we used to do because ultrasound is now very much better, and they look at things like called the resistive index. And this is an ultrasound, and as the resistive index goes up, the kidney has got issues. So instead of getting a really nice flow on the Doppler, you get this very poor flow, and that means the patient's probably in rejection. And the big advantage, of course, is that you can take the ultrasound machine to the patient, whilst with a transplant renogram, you've got to bring the patient down to nuclear medicine. So there are some differences between the two. With MAG3, it's quantifiable and reproducible. So it's useful if you've got a patient who's unwell and you want to monitor progress. It can reliably identify an infarcted kidney with that black hole type picture. And you can find slow leaks because you can image up to 20 hours, to be honest, looking for leaks. Doppler ultrasound obviously contains no radiation. It's a bedside test. The resistive index does correlate well with rejection, but not reproducible. So it may change between scans because the operator does different things with the Doppler, but it doesn't really tell you how the patient's doing. So the last thing I'm going to talk about in transplants is DMSAs. These may be useful to look for scars. So normally we would say with an adult, we don't do DMSA for scarring, but transplants are different because they have a short ureter, and also because they're on immunosuppressive drugs, they can have infections. And this is a series of patients that we did, that we published from my old hospital at the Royal Free. And we can see that they can have multiple scars, but also you can see vascular damage on the DMSA as well. Now, everybody ignored this paper for about 10 years, but suddenly it's all become very trendy again, and people are now doing a lot more DMSAs in transplants. So this is a few things that we could see. So that if you've got scars, you see a normal sized transplant with focal holes in it. He's looking at 3D images, which are a very nice way to see them. A rejected kidney looks very small with very poor uptake. And this is a vascular damage, and you can see that just sort of the top half of the transplant's just disappeared because the artery to it's been blocked. So you get these three kind of patterns. So quiz time. This is a patient who's had just a planar DMSA. We did it at 2 hours and 3 hours. How many transplants has this patient had? You can unmute yourself and tell me how many transplants has this patient had?
I'll say 2, Prof.
2, good. Okay, that's a good number. You can see 2, can't you? Any other answers? Any advance on 2?
Prof, I'm thinking 3, because maybe there was one on the left that we're not seeing.
You mean this faint one here? This one here? Well, sorry, I had my arrow on. Yeah, that could be. Yeah. Okay, yeah, I think you could have 3 there, couldn't you? So I think the answer, so these are the native kidneys. That's the old, slightly dead adult kidney. Why are there 2 kidneys here?
It's possibly the donor was a child.
The donor was the child and the recipient was an adult. So they decided to use both kidneys. Unfortunately, the donor was a very small child that had a brain hemorrhage. Obviously, you can transplant a child's kidney into an adult, but you can't transplant an adult kidney into a child. That doesn't fit. But anyway, yes, it's 3 transplants. Well done. I think some of you may have seen that before. Okay, so in summary, with renal nuclear medicine, we get unique functional information. Different studies, whether or not they're renography or DMSA, can look at different aspects of renal function. Studies are quantifiable, so can be used to compare patients over time within an individual patient. So you can see when not an intervention is working. And the big advantage, of course, is that you don't need to have fancy PET scanners to do this. You can do this with just straightforward gamma cameras, even non-spec gamma cameras. So it does have some significant advantages over the use of other imaging techniques such as CT, MRI, etc. So we should still really be in the business of renography. Thank you very much. No, that's just not what I wanted to do. I think I've got to try and stop this thing from recording.